Welcome, everyone, to Beauty and the Surgeon podcast. I'm Amy. I'm a nutritional therapy practitioner, and I'm joined today, as always, last week I was by myself.
Yeah, where was I? Where was I?
You guys
last
are
week?
back, so I'm joined today with
Is
Dr.
Nils here?
Jason Martin. He's a board-certified plastic and reconstructive surgeon. I'm just going to keep talking over you guys. And our wonderful producer, Nils. If you guys did not watch our last episode, which came out 2 weeks ago on June 1st, it was my top 5 of the year so far.
Let's go.
And one of those episodes featured Nils quite a lot, and I loved it. It was the future of plastic surgery, so definitely go back and catch up if you have not, because the year is halfway over. It is June 15th. It is Father's Day.
Whoa.
And we are halfway through 2025.
I know, it's crazy.
How does that feel?
Yeah.
All right, let that sit.
I feel like it doesn't matter where you are in the world, people feel that way. Like time is just weird, the way it works.
Goes fast.
And it does.
Yeah. So this episode, as I teased in my last episode, is all going to be questions from you, the listener, and some comments. We have some great comments and some really good questions. I've been saving them up. So if you left a comment or a question within the last 4 or 5 months, really, because it's time goes by so quickly, it's probably going to be answered in this episode. And since we're recording even today, we got more questions. So there will be more coming toward the end of the year. But for now, if you're not following us on social media, you can find all of those social media handles here. And you can also watch us if you are listening. We are on YouTube at Beauty and the Surgeon podcast and at Jason Martin MD on YouTube.
Yeah.
So that's all I've got. You ready to get into some questions?
I think, it's fun to watch on YouTube because you get to see Amy's glasses game or San's glasses game. So you're not wearing them today.
I rarely do.
Yeah.
And the flower game, that changes.
Yeah, the
too.
flower game's really good too.
The flower is consistent. The glasses are rare.
There.
Yeah. All right. So let's get into the questions from listeners. And this is a 2-part. So this is part 1. There were so many, I did have to break it up. So the first part, we actually got some texts and a voicemail. So those are going to get...
I love DMs.
They're going to be our top ones. So this first one is a little bit longer. This is from Sarah. She says, "Hi, my name is Sarah. I live in Florida. I recently discovered your podcast after watching your YouTube videos, and I enjoy it so much. I love to learn about all things aesthetic medicine. I just turned 26 and am showing some signs of aging that I believe are partially genetic." Well, yes, because I use my face. They're entirely genetic. Yeah,
that's true.
Because I use my face as a performer in my line of work, I am so scared to do anything that could potentially change the way that I look.
That's a good point.
I've listened to multiple episodes regarding Sculptra, blepharoplasty, under eye hollowness, etc., and I can't find a solution that I feel would be safe at such a young age. I've had doctors recommend fat transfer and others swear by filler. Can you help me? Can you help provide any insights as to how someone who's younger like myself could rejuvenate an under eye area that is so dark/hollow? I had a septoplasty about 2 years ago, and the surgeon told me I have incredibly thin skin under my eyes, as we all do, Sarah, making it
How
so
is
much
that
more
even
visible.
A helpful comment?
It's not to a woman who's at the time was 24.
That's probably related to the fact she had bruising with it, and he was blaming it on her
The thinness of the skin,
which is such a, I don't know, whatever.
I appreciate you taking the time to hear from your listeners. Thank you so much. So.
Awesome.
In a nutshell, Sarah's 26. She's a performer of some sort, doesn't want to change her appearance, but doesn't like the hollowness under her eyes.
Do you think she's a mime? Is there possible that she's a mime? Do even 26-year-olds know what mimes are? I mean, is that a thing anymore? No, not really.
I don't know.
Yeah, who knows? Anyways, all right. So under the eyes, hollowing under the eyes can be present since birth. You can look at babies, they have hollowing under the eyes. That's definitely somewhat related, or in large part, or 100% related to your anatomy. Your anatomy is dictated by your genetics. And you could see that earlier. It worsens over time because the ligaments around your eyes loosen, the skin loosens, the fat on the lower eyelid herniates, and then you get deeper tear trough or that hollowing underneath the eyes. So this is a common problem people come in for. Now, if you're older, maybe 26 is kind of young, but if you're older, a lot of times these patients are really good candidates for blepharoplasty, so lower eyelid procedures where you remove the fat, transpose the fat, elevate, resupport the lower eyelid, and make a big difference. But Amy, at a 26-year-old, what is your first feeling about that with what she's saying? How would you approach a 26-year-old like this?
Yeah, that's a tough one because I would probably tell you to wait a little bit until there's a more definitive solution.
Mm-hmm.
We do have some other options. Hollowness is a more challenging thing. Now, if you had puffiness, that's different. But with hollow and the dark is probably not going to be changed by anything like that. And I would not recommend fillers if that's the case, because it can make that dark appearance in some cases look a little bit worse. If anything, I would say if you find somebody who's really adept at using fat, that doing a very conservative fat transfer would be a much better idea than filler.
And why do you say that?
Because like I said, the risk of the deepening of the darkness.
Yeah, I'm not sure I totally agree with that, because I think that no matter what, filler or fat in the tear trough, theoretically injected correctly, is going to improve that invagination area. It's going to soften that up. But the darkness is pretty much related to the pigmentation. Wouldn't you assume that?
Yeah, and some people, that's just, again, anatomy and genetics. Like some of that's just you. And that's why I said I would get away from feeling like there's a solution for that.
Right.
Like I would try to not do anything that would make that worse.
Right.
Because it's likely just the case. You know, and you do have the benefit of being a woman, you know, you can cover up the darkness.
Yeah, with makeup. Yeah, so historically, and Amy has helped me with multiple patients like this, people that have pigmentation issues in the tear trough area, you can use some of the lightening creams. Like what? What would be one of those?
They're not going to lighten the darkness.
Okay, yeah. So
they're not. So I wouldn't. I wouldn't recommend using them under the eyes.
But what are those creams?
Well, there's topical bleaches, but those things bleach pigment like brown.
Yeah.
Like they're not going to address that, like the purpliness under the eyes.
Exactly.
It's totally different. Like those bleaching creams are attracted to melanin, which is not the cause of the darkness under the eyes.
Right.
So it would be not useful.
Not useful. Now, some people do have pigmentation changes there, especially around pregnancy, masking, and all this kind of stuff. And those bleaching creams work. But for someone like you, it's probably not a pigmentation issue. It's probably more of a hypervascularity, or as Amy was saying, like a...
Well, and I have very dark under eyes, and you don't. You know, some of that's just, I have a ton of cover up on them all the time because they are very dark. Even as a child, like people would like ask my mom if I was getting sleep because I had very dark under eyes.
So funny? I don't think of you as having dark under eyes.
Oh, they're very dark. Like really, like purple on the inner corners.
That's so funny.
Yeah.
Even when we're in like with patients, I'd say, well, Amy's under eyes look amazing. Mine look like crap. And you're telling me it's just cover up. So why didn't you give me your cover up?
Because you don't need it. That's what I'm saying. You do not need it.
Right.
So
anyways, that pigmentation, I'm just getting to a point when Amy's making it, is really not going to probably be helped with a bleaching cream and lasering. The invagination or the contour issues between your lower eyelid and then that tear trough can be helped with fat and filler. One of the reasons that Amy's implying, and she didn't say it, but I'm kind of reading between the lines with filler, if you get too close to the skin, it can give a blue hue to it. And then that can lead to discoloration also with the filler. The fat is less likely to do that, but the fat is not removable, and the filler is with hyaluronidase. So there's always a catch-22 with each of these things. My general feeling, I'll disagree with Amy, which is unusual. I think you start with fillers, a subtle amount, and see if at least improving the contour makes you feel better, because fillers are reversible. But then you quickly pivot to fat in the long term, because that's going to be a long-term solution and probably look better.
Right. Well, I wouldn't start with something like Sculptra.
Yeah. Sculptra, what you mentioned in your...
Because it is hard to remove.
Yeah, in this text or whatever, or voicemail or whatever. Sculptra, I would definitely not use anywhere near your eyes, period. So I don't even think that's an option. That would be more mid-face stuff. That's usually injected deeper, causes chronic inflammation, doesn't go away. So you're never going to, in our world, you're never going to use Sculptra around the eyes.
But the main thing I would say to Sarah is that you are only 26, and there will likely be better options. Listen to our episode about the future of plastic surgery that are coming, by the time you might be a candidate for something like a surgical intervention in 10 to 15 years, there may be a better option.
Yeah.
So and that's why I start off by saying, I would say wait, because all of these things right now have the potential of making things slightly better, but none of them is a solution, a 100% solution. And this aging process, especially if you're seeing these signs of aging at such a young age, are going to kind of, snowball on themselves.
Right.
So you can always do more, but you can never go back.
Right.
So jumping into something that could, potentially lead to the need for more and more and more surgeries, the earlier you start that process, the more it's going to need to be maintained or changed or adjusted, especially with the lower eyelids. That is one area, as you know, she said she's a performer. You don't want to do anything that's going to change the way you look.
The shape of your eyes.
Right.
And that's the main thing.
Or the expression around them.
The way the eyelids work.
Yeah.
So we have done lower eyelid surgery on people in their 30s for sure. Mm-hmm. If you go to more surgery for places like Miami and LA, You're in Florida, so maybe you are in Miami. They're going to be doing these more often than in a place like Denver, which has a more natural aesthetic. But it's not unusual for us to do lower eyelid or eyelid surgery on people in their 30s, and they have premature aging. They have evidence that is different than their chronological age. So you may be one of those people. My recommendation, which is hard to say without seeing you, is... And
don't send us a picture, please. She's offered, but we can't. We cannot do that.
Yeah, so that's inappropriate. You can always do a telehealth appointment, consult. But that
would be for a real patient.
Yeah, for a real patient. But you can... I would start with a real kind of subtle filler, something that's very viscous, not super volume filling. And I would start from there and kind of see how it looks along your tear trough. People that are reputable injectors or plastic surgeons can do that for you in the Florida area.
Yeah.
So,
but thank you so much, Sarah, for listening. We really appreciate it. All right. The next one was also a text. So this one was, doesn't liposuction before brachioplasty cause blood flow issues for healing? Also, what kind of suturing do you do? Have you heard of the pie crust stitch? Assuming she means a half-buried mattress.
Yeah, I think she's talking about a half-buried mattress.
Yep. Mm-hmm.
Who is this person?
This was a text. This is all I know.
I feel like this is name. Like a competitor.
Yeah, but I think this is a great question.
It is
anonymous.
Really yeah.
It would having liposuction, if you were considering a brachioplasty also, would that compromise future blood supply to the flap of the brachioplasty? That is such a great question.
Such a very good question. Mm-hmm. We actually do lipo right before we do the flap for the brachioplasty in a brachioplasty. Mm-hmm. So immediately, no, it does not, because that's what I do on a regular basis. And long term, if it doesn't hurt it right away, then I think long term, it's probably not going to affect the blood flow over time. You would not want to do a brachioplasty like 3 weeks after doing liposuction. Right. So
let it heal.
It would have to be like a 6 months to a year out. And then I think that if you don't have any other health problems or other circulation problems or things going on with you, if you're just a standard healthy patient, it probably should not affect the blood supply. What kind of suturing do? I do all different types. I do the deeper sutures, which is a superficial fascial system. And I do superficial sutures, and then I do a running suture also. So I do all different types. And the pie crust stitch, which I've never even heard that term, I'm assuming is a horizontal half-buried mattress suture. I definitely do that all the time. And what that does is avert both sides of the incision line.
Takes the tension off.
To take the tension off. Now, if it's a pie crust stitch because it's something that kind of grabs the deep dermis and brings it together, and that absorbs over time. So it looks distorted, kind of pie crusty at the end of it, and then it softens out. I don't do something like that with my brachioplasties because my brachioplasty scars look really, really good long term. So adding extra maneuvers, at least in our experience, is not helpful.
Yeah. But I thought that was a good question. So I think going to someone reputable for your liposuction is key. Bad liposuction can have issues related to future healing in general, but good liposuction does not, as you said.
Right.
Yeah. So anonymous, great question.
Good question.
Thank you for texting. I don't know your name. The next one is actually a voicemail. Okay. We only got one voicemail this round. So,
hi, Amy. I listen to your podcast. Love it. Can I make a suggestion for either a question that you would answer or a whole episode? Because I think you could make a whole episode out of this, where you would talk about GLP-1s and plastic surgery. Because I know a lot of people are taking them. If you could talk about, does this affect your body for plastic surgery? What are the statistics of people who are having on GLP-1s and having plastic surgery? Has it changed? Has it increased? What are the concerns, the risks? There's new research out in December that you're probably aware of that suggests that GLP-1s might affect tissue quality above and beyond just weight loss in general. Has Dr. Martin seen this? If he's giving facelifts, is he noticing differences in the facial tissues of people? And if so, what recommendations might he have for people who are on these medications, who are considering future surgery? Okay, just a thought. If you guys could consider that would be amazing. Take care. Bye.
So, as Nils noted, there was no name. So, again, anonymous. But Since this voicemail was left, we did have our episode, The Future of Plastic Surgery, where we talked specifically about weight loss surgeries and GLP-1 usage. Dr. Martin also brought up GLP-1s in our last research we're into. So it's definitely something that we talk a lot about because, as this listener noted, it is very topical. Interestingly, I had not read any research or studies about skin integrity with these medications, but it is anecdotally something that Dr. Martin and I have talked about a lot.
We've seen, thinning of the skin, looseness, lack of integrity, lack of elastin, all that kind of stuff.
Above and beyond what we see in I'm going to say normal, in non-assisted weight loss. And this is I'm not throwing shade in any way, because we definitely see patients who have lost a lot of weight through just their own means,
right?
Through surgery, and now through GLP-1. So we have seen, a lot of patients who fall into all of these categories, and there is absolutely a difference in the skin of people. People who've had bypass, who've lost a lot of weight. And you see a lot of those same things in GLP-1. And I really feel like a lot of it comes down to a nutritional deficiency.
Yeah. And also the speed.
Speed. Yep. And nutrition. Because there is something you can tell. You can see the way a person looks and the way their skin reacts even after surgery that is just different in people who are using GLP-1s.
Yeah, I've heard the term Ozempic face, where it's just like you see that more in like the actors and stuff now, where you're like, oh, like you can almost tell immediately that they're, they've taken that route.
It's so weird too, because you think about like GLP-1s and you talk about Ozempic phase, and there's a lot of data on that. Number one, with any kind of weight loss, there's a protein or a muscle loss. So if you're not doing a Herculean efforts to maintain muscle when you use GLP-1s, you're going to end up in a bad position. And some of that muscle loss and foundational loss can be in the face. So people look very depleted.
And bone loss.
Yeah, and bone loss too, especially if they're not nutritionally sound. So that's the first thing. And secondly, just the speed of weight loss with these things is like jet fuel of weight loss. People do not look great, especially in the process of that. Now, that may equalize out over 6 months or a year after you stop these things, Which
is why we won't usually do surgery on someone who hasn't maintained a stable weight for at least 6 months.
Right.
And the recommendation after bypass is a year. And I think that recommendation should, in most cases, be the same for GLP-1 medications to allow the body to have that homeostatic kind of, leveling off, and also for the person to be able to understand how to get in enough nutrients to support overall health.
Yeah.
Because these drugs, let's not beat around the bush, they make you lose weight because you are eating less. That is 100% the way they work.
Right. People think it's like some magic wand.
No, it is not.
It must be the G in GLP that does it, No, you literally eat less calories.
Yeah. So if you are under eating and you're malnourished, and you might even be micronutrient malnourished. So my recommendation for people using these is to work with someone who can help you understand nutrition.
Yeah.
And perhaps do that first, and then see if you still need to go on the GLP-1.
Right.
Like make this a lifestyle change first, and then use the drug as an adjunct, not the other way around.
Right.
Don't just use this drug, lose a ton of weight, and be like, oh, well, now I have osteoporosis and I have muscle wasting.
Because I think a lot of people with GLP-1s, if they don't go to a reputable place that has a nutritionist there, or at least a system in place where they're really monitoring what you're eating, all the stuff that Nils and I were talking about beforehand, which can be annoying, but you kind of have to do it. You have to really get the protein in. You have to try hard to do these things, especially when you don't want to eat.
Right. Well, because this is a classic situation of cart before the horse. Like they're literally just giving people the cart, which is massive weight loss. But if someone has gotten to this state, there's potential there that they may not understand how to maintain a healthy diet.
Right.
Especially at a very low intake.
Yeah. Now, GLP-1s have amazing benefits for people that have diabetes or type 2 diabetes. So that's a carve out. So if you struggle with type 2 diabetes and you're given GLP-1s for that reason, it's an amazing drug, and you just have to accept the side effects,
and weight loss in those patients is different.
Yeah.
The people who have type 1 or type 2 diabetes who are put on these medications don't have the extreme weight loss that an average population has.
Right.
In clinical studies.
To qualify for GLP-1s, for insurance coverage, I think you have to have an elevated hemoglobin A1C and things like that. It's my understanding that most insurance carriers won't cover it just for weight loss. Now,
there are brands for weight loss. So there are two versions. Okay. There's a version of each that are actually for weight loss only. So you just have to have a BMI over a certain percentage.
Okay.
In those cases, that's the only.
I understand.
All you have to have.
All right, that's good. Yeah. Good clarification. Sorry, we're not in that world, so we're in the cash pay world. But the world we are in is the cash pay world, and we do deal with patients who paid money just to go into a clinic and take this just purely just for weight loss itself. And there is a secondary realization that, man, there's a big change in your body and things that maybe aren't great either. So overall weight loss, lowering your body fat percentage, improving your BMI has health benefits that are amazing. So it's a hard thing because with GLP-1s, it's very successful for most people that we've seen, at least anecdotally speaking, looking at the data. But the secondary results of that can be a problem. And we, in our clinic, are seeing the results of that now, for sure. Maybe less here, but some of my other clinics that has a population that's more obese, the results of that are people coming in with severe skin laxity, severe issues related to their bodies and face.
Dr. Martin, if someone was to take those injections away from them, what do you think would happen?
I mean, they may gain the weight back. So,
yep. So I think that's also why I think looking at these in the reverse way that people are looking at them now, like address the dietary and lifestyle factors first, or at least at the same time, instead of waiting until after and you're like, wow,
right,
now I'm going to work on building muscle. Like, what can you do to make this, to potentially mitigate some of these negative side effects, is to do those things first or at the start of things, rather than being like, well, now I lost 50 pounds. Like, now I'm going to work out.
Yeah.
And that's what I hear a lot of people doing.
To your point, taking a step back from GLP-1s, which we're supportive of, and they have amazing potential to help society. And you can go back and listen to the one we were talking about. There it is. There's the episode, whatever episode that was.
The future
of plastic surgery. Yeah. Okay.
Well, Nils is like, no, you have to be specific.
Yeah. Okay. Yeah. Exactly. Sorry about that. Sorry.
This episode.
I'm so lazy
Read
now with you, Nils, because you're such a good editor. You know?
Right. In the future, Nils, you'll be able to read his mind.
Yeah. AI Nils.
Mm-hmm.
But in reality, it's not really about the GLP-1s. It's about calorie restriction and nutrition. And you take anyone, bariatric surgery, someone who just literally goes to a super low calorie diet and, borderline starves themselves, or a GLP-1, you're going to have all these same problems. It's not like GLP-1s are taking away muscle on their own. It's just really, it's a high majority of it is the calorie restriction, which, by the way, they're going to come out with medications that preserve muscle and allow for...
I believe that's a myostatin inhibitor.
Yes. Yeah. So these things are coming in probably the next few years, and that's going to be even more transformative. So we'll have another discussion then. But for now, if you're on a GLP-1, that's great, but you just got to prioritize nutrition. You don't want to come in nutritionally challenged. Secondly, around the time of surgery, GLP-1s aren't great because, at least with the data, it shows that they have a higher incidence of reflux or slow gastric emptying. At least that's the historical data. And that can lead to people having vomiting episodes during or after surgery, which can lead to problems like pneumonia and stuff.
Well, and leading to malnourishment after surgery, which,
right,
if you've listened to any of our episodes about recovery, you should definitely not be in a calorie deficit during recovery. It will impede healing on every level.
Just one last thing. In terms of soft tissue and skin, I don't think GLP-1s exactly cause these problems. I think it's the secondary effect of
the weight loss,
calorie restriction. Yeah. So I have not read data where GLP-1s are causing these problems like directly. It's the indirect result of the mechanism of action.
Right. That's why I started off by saying, like, let's not kid ourselves. This is through calorie restriction that's happening, and nutrient deficiencies can happen very easily, especially in a class of drugs that causes people to not feel very good. So what do you start doing? Well, like, I'm nauseous all the time, but so you might eat something that is tasty rather than nutritious because you're barely eating at all.
Right.
So I'm going to eat this tasty thing,
which I do when I'm sick. Actually,
exactly.
It's so funny.
Yeah. Rather than eating, something that would give you more micronutrients. And I'm not giving a healthy. I'm not saying it's healthy. I'm saying you need to be eating nutrient-dense food instead of tasty food, probably.
The irony of GLP-1s is that a lot of people get these from their internists and think, and we're thankful they do because it's changing their life.
I would say most people are getting them from a med spa.
Okay, well,
I wish it was from their internist.
Let's just say it's a good situation from the internist. And these internists primarily are not big believers in cosmetic surgery, nor what we do for a living, even though I think we do transformative surgeries. But they're just driving people into our office, which I find really fascinating. So their desire is to improve their life, but the secondary results of that is loose skin, a lot of body and face changes that have consequences. And there's no discussion with these patients beforehand. We have literally had GLP-1 taking patients come in who are like, I did not expect this.
Well, but anyone who has seen a bariatric patient should expect that.
Mm-hmm.
It's weight loss.
I feel like the bariatric patients get more of a discussion than the patients who get GLP-1s. Like the bariatric patients that are saying like, you might end up doing, at least plant the seed. So they don't feel like, wow, I never expected this kind of thing.
Yeah.
I don't know.
But like you said, there are benefits of weight loss.
Yeah.
So
do the bariatric patients get a little bit more information on nutrients because
they get far more.
Way more.
Right? Because
Yes.
that's a big part of it because they're like, we're taking out a
Right. They're
piece of your
it's
stomach,
a
right?
malabsorptive surgery.
Yeah.
So not only are most reputable bariatric surgeons require that their patients start working with a nutritionist and a therapist.
Yeah.
Before surgery.
Yes, for months before surgery,
Months
because they
before.
know that if they don't, the
Success rate.
relapse rate is extremely high.
Gotcha. And that doesn't seem to be the case as much for the GLP-1s.
No, because most people are going GLP-1s now. They're not qualified because they're diabetic or with their internist or just walking into a med spa and they're paying for it.
Right.
Gotcha.
Or they're getting them online. I mean, there's very little regulation on this class of medications at the moment. Yeah. All right. So sorry, I know we talk about that one for a long time. So we have a lot of other questions to get to. So we're going to have to move on. But we have talked about this in a lot of episodes, and it will continually be a part of the conversation.
Yeah,
I'm sure. So.
These are the more common.
Yeah. All right. So this one was from Lady Nip Chick 2. Everything you need to know about facelifts, part 2. Said, this was very good. Tell me, has this lady had a facelift? And I did verify with them who they were talking about when they said this lady, and they were talking about me. And this lady has not had a facelift, but she would get one. She will get one. I'd have one today. So, nope, I have not.
You're just you're God, nature given pretty.
Well, but that doesn't mean I won't need a facelift.
That's true.
Facelifts do not have anything to do with beauty.
That's true.
It's aging.
It's just the clock.
Yeah, aging is different than beauty.
Yeah.
So
that was a nice compliment.
It was, yes, but no, or not nice. So it was nice to you, or it was nice to me. So I would say this one was nice to you because they thought you'd done such good surgery that they couldn't even tell. All right, we're gonna take a quick break. We're gonna come back and do some more questions from you, the listener. And we're back. All right. So our next question. I became Southern.
I knew that Kentucky would come out.
The question. This one was from Roxy. Yep, Roxy 6902.
Yeah,
I know
like
you guys.
Roxy.
I've told you how I feel about the numbers. They're messing with my mind. Everything you need to know about thigh lifts, part 1. And she said, "What did she mean by the stupid holiday in February?" And what I told Roxy was that I meant Valentine's Day. I was not trying to say anything bad about President's Day or Groundhog's Day. I meant Valentine's Day. So I apologize for degrading Valentine's Day.
And you stand by Valentine's Day not being a good day.
Well,
So I do.
I mean, it's kind of a ridiculous holiday.
I kind of
But
like
I'm all
it.
for love, and I
like
love
it.
pink. I
You-
mean,
you like love and
Yeah.
presents and stuff like that. I mean,
Yeah.
you're down with that.
it's more the forcedness of the day.
Yeah, that's
Yeah.
true.
Yeah.
I've never minded it. I've never felt one way or the other about it.
Yeah, I
like
mean, it's fun.
I like doing stuff for my wife on Valentine's Day,
Yeah.
but it does seem kind of a contrived holiday at this point
Yeah.
in our lives.
Right. But I'm
But
sorry.
that's
Yeah.
probably age related too. I guess when you're in your 20s and new love, I mean, Valentine's Day might be nice.
You can have new love at any
Yeah.
age.
So what are the holidays in February?
Well, there's Groundhog's Day.
Yeah, I got that one.
And there's President's Day.
Yeah,
And there's Valentine's Day.
that's it, right?
And
There's no
it's
other
a short
holidays.
it's a short
Yeah.
month, has a lot of holidays.
Okay.
Yeah. So I apologize, Roxy.
Yeah.
All right. Okay. So we had a couple of questions on, I don't just list positive things. I bring up other stuff. Everything you need to know about brachioplasty, part 2. We had 2 questions and a comment. So we'll start with the first one. This was from Emmett Carlson 2739. This was the first plastic surgery I did in Malmo, Sweden, after I lost a lot of weight. The results from this kind of surgery are amazing. I don't have to hide my arms or myself in a hoodie anymore. It gives great freedom of my body expression now. Smiley face. Thanks to you two for the great information you give.
I love it, Emmett. I love it. These are the type of comments that just really keep me going, man.
Yes.
So thank you.
And the scar,
Yeah, who cares?
Exactly.
Yeah, and the fact that you don't have to wear hoodies anymore, that's my love language, man.
Yeah.
So this is great. I love it.
So this next one came from Aaron Enjuenhard.
Yep.
4015, because
Okay.
everyone has numbers. And I haven't actually gone back to listen to this episode, so I don't know.
Oh,
but
no,
we're
no,
gonna
I
ask
know
you.
this comment. So by the way, I rarely read comments. This is an absolute truth. And I just happened to go down and he said, or this person said,
Right, because you have to
he or
remember,
she.
Dr. Martin, not everyone is watching this, so let me read it.
Okay, good.
So this was the question.
Yeah.
Did he say dire wolf?
Yeah, I did. So I did say woof. I am from Kentucky.
What is a dire wolf?
No, but like it's a wolf with an L, but when you're from the South, you lose syllables in words and they just disappear.
So is a dire wolf a type of
a dire wolf is an extinct wolf.
Giant wolf.
Oh, this was
They're
the
really
DNA
cool.
thing you guys were
Yes.
talking about.
This
That
is-
was also in Game of Thrones.
yes,
Mm.
bringing back the dodo is what brought this up.
Yeah.
So,
Mm.
And the
Yes.
Starks had dire wolves. Each of them had one. It was an amazingly rare animal in the show, and they're bringing it back. And I did say wolf. There was no L. I said woof, like you're woofing.
Dire wolf.
Yeah.
So yes, Aaron, he did
you
say
read
that.
comment?
yeah, I did.
Yeah. Okay.
I was going to say visit our episodes on the toilet, the toilet,
The turlet.
the toilet.
He also
See, I
says
can't even
he also
say
says
it.
sconch.
Scott.
And I'm like, what is he talking about? He means sconce.
Scott.
There's no H.
I love it.
in sconch.
Sometimes I wonder if the way I
wolf
say it
is
is
cool.
correct and the way everyone else says
Yeah.
it is incorrect.
Well, a dire wolf could be like the baby. It'd be cute.
The wolf, or that's what a
Oh,
dire
the
wolf.
dire wolf.
Yeah.
He's like a puppy. He's the puppy. Aw.
You know, it's very funny.
Nils, can you AI me a dire wolf?
There you go.
I'll hold one.
So the funny thing is my kids make fun of me because I those things, I don't have many of those things, but they definitely come out. And they're like, what did you just say? You know, like I get completely beat up at home.
Well,
But that was a very good comment. So any kind of comments that make fun of the way I say things, I'm all for, actually.
yeah, well, there's a lot that I say too. So yeah, see, this is what I mean. We like all comments. Okay,
Yeah.
so we did have a question on this episode as well. And this
Yeah.
one was from Patty Dibb 7976. She said, this was a really informative video and a
Nice.
great follow-up to part 1. I am recovering currently from brachioplasty, and everything you covered was exactly on point and pertinent. I watched several of your previous episodes on various topics, including how to help your recovery from surgery in general with supplements and a good diet. I took copious notes and have been following Amy's suggestions with really great results. Thank you for all you do. For a possible future episode, I'd be curious to hear your thoughts and expertise regarding fixing dog ears and scar smoothing if there is such a thing. So we do have an episode where we talk about scar revisions.
Mm-hmm.
But Dr. Martin, like specifically to brachioplasty, what do you think about dog ears? And
Number one, you should not have a dog ear with a brachioplasty.
I mean, I could see if it was at the elbow.
But if it's
We've revised one at the elbow.
So, and yeah, Amy's absolutely correct. The area where it would be the distal part, like near the elbow, because, you know, all
You
of us,
gotta
me
end it
included,
somewhere.
you got to stop, and you want to stop before the elbow joint or at it. You don't want to go past it because it defeats the purpose. You start getting into the forearm, and then it's a lot more visible. So that people have reticence to chase it past the elbow joint. Also, joints tend to not heal as well over a
elbow.
joint.
Yeah.
There's a lot more tension. They're moving, so the scars can look worse there. So, by the way, fixing dog ears like that, especially for brachioplasty, are not hard. It's done in the office with us, under local anesthesia. It would take you 20 or 30 minutes.
It
at
does
most.
sometimes mean, though, that you have to extend that scar a little bit.
Yeah, that's the difference.
That's the trade-off.
Yeah, I mean, that exists in a lot of things I do. Direct excision neck lift. I don't ever want to go down to where at the base of the neck onto the clavicle, which is that bone. What is this called? Your chest bone? I don't know.
Your clavicle.
Clavicle. What do people call it?
Collarbone?
Collarbone. Thank you. It's down past your collarbone. Way to go, Nils. Thank you for Google
Thank you,
translating
the
doctor
layman.
stuff.
Yes.
So yeah, I've had to redo one there, so that's pretty infrequent. But yeah, they're pretty easy to fix,
Mhm.
actually.
Yeah. And the recovery is usually not bad. As we talk about in our scar revision episode, little fixes on a scar are rarely as involved as actually recovering from the procedure itself.
And dog ear. Sorry, one more thing. Dog ear is usually two things. It's a little extra skin and a little extra fat. So when you do the dog ear excision, you're taking out skin, but you're also taking out some soft tissue there, usually.
Usually, yeah. The scar smoothing, there's a couple options if you have a scar that is, and we talk about this again, I'm not going to say it again, but in the scar episode, there's Kenalog injections, which is a steroid that kind of helps break down the like thicker parts of the scar. You have to be careful that you don't cause a divot, because if you overutilize Kenalog, it can cause the
Fat loss.
Yep, little divot there. Also, just topically, I mean, things like microneedling or some laser treatments can be really beneficial in helping that collagen behave
Mm-hmm.
and like lay down properly. Even just the tactile act of massaging a scar is one of the most beneficial things you can do to help it smooth out and flatten.
Absolutely. Yeah. Any things that cause pressure to a scar can make the collagen realign. Scar creams are excellent. Both the scar
silicone.
onlay, silicone sheets, and creams themselves work really, really well.
Yeah.
So look at our scar episode because we have a lot of information on this.
Yeah. And congratulations on your surgery, Patty. That's awesome.
That's awesome.
Yeah. All right. So this next one was a comment on supplementation around surgery. And this was from Sharim658. And she said, my surgeon has me taking arnica, vitamin C, rutin, and vitamin K 2 weeks prior to my surgery, which I said, that's awesome. The only one of these that we would not recommend is rutin.
I was going to say rutin.
Mm-hmm.
Were you going to say rutin?
Yeah.
Nils?
I don't know what rutin is.
I don't either. That's why I was going to say. What is rutin?
Yeah, there's no data on it. I mean, the claim is that it can help with anti-inflammation. However, it can also have an effect on blood sugar regulation. So that's why I wouldn't have somebody start it before surgery. Go ahead, Nels.
Oh, no.
You had the microphone in your hand. I was waiting. Oh, okay. Yeah. So, but if your doctor has cleared it, I think that's totally fine. It's just when I look at supplementation, I really try to look at things that actually have real data behind them and a real purpose. I always tell people, like, know why you're taking what you're taking. And is there a better option for that potentially? But the vitamin C, the vitamin K, I mean, awesome. And the arnica, starting at 2 weeks prior is maybe a little early on arnica, but at least a few days before surgery is good just to kind of get it in your system. And ultimately with supplements, the best supplements, especially around surgery, are it's getting in the habit, because then after surgery, when your life is kind of thrown into chaos because you're recovering from surgery, you're just so used to it that it just is part of your routine.
Yeah.
So
Yeah.
I thought that was awesome though. Yeah.
Still one of our better episodes, the supplementation around surgery episode.
And we have 2, right?
Yeah.
No, we have
One.
There's 1.
I mean, we've covered it in different
We
things,
cover it
but
a
there
lot.
was the one main one,
Yeah.
which is now 5-6 years old,
At least.
something like that. Yeah,
We should redo that.
back
It's
there.
older than
update
that,
it.
Nils, because it was
Is
pre C19.
Oh,
yeah,
man, we
that's
should
right.
update
So it's
it.
at least 6 years
We
old.
should
So
update it.
there'll be some updates coming.
All right.
This next one was a comment on everything you need to know about blepharoplasty, part 2.
From Princess KLG.
Princessa.
Princessa KLG.
KLG.
I like that. I like that name.
She said, love the tracksuit.
Yeah. Okay. Thank you. Thank you, Princessa.
Nils, you got to insert the tracksuits here. So I have the tracksuit pictures saved individually, me and Dr. Martin by ourselves, that I use as photo emojis that I respond to people with.
I mean, and to basically to you and I.
That's what I mean.
We send our photo emojis of us in tracksuits back and forth.
I send it to you. I send it to my
It's like a
front
thumbs
desk.
up. It's just like, track
Right,
emoji.
like I got this.
Tracksuit.
I mean, really, and Nils, I keep meaning to ask you, I would love for you to do one of Catherine so that I can send one to her all the time too. I'll get you a picture of her.
Yeah.
I got a photo library YouTube, but none of Catherine.
Yeah, no, I'll get you a picture because she needs a tracksuit too. Catherine is my assistant.
That's actually everything you need to know about blepharoplasty, which is right here. That episode is actually really good. So you should watch both 1 and 2.
Yeah. So thank you for the comment. We loved it. So that brings us to the end of part 1.
Yeah.
In part 2, we have a lot more questions. And I mean, like, I had to finally cut it off because there are so many. So if you did not hear your question answered in this episode, please listen in 2 weeks on July 1st. Cue the fireworks. There will be an episode where we answer the rest of the questions. So
We might bring a dire wolf into the studio so everyone can see what it looks like. Apparently, it's as big as a human.
yeah,
It's huge.
I mean, wolves are big.
They're big, but like a dire wolf, not with an L,
Is even bigger?
Is bigger. Yeah.
Okay. Well, until next time, thank you guys all so much for listening. And if you made it to the end of this episode, I greatly appreciate it. You can find all of our social media handles once again here and in the description box below. There's also a link in the description box, as there is in every single one of our videos, about how to find a plastic surgeon.
Nice.
I recently sent it to someone who told us that they went to see a doctor and she goes, I don't even know if he's board certified. I'm like, oh, well, let me show you where you can find that out. So definitely check that out, and look forward to seeing you here next time for the rest of the questions.
All right. Part 2 coming up.